Delayed recognition and treatment of infections in dialysis patients are important causes of hospitalization, morbidity, and mortality. Access site infections are typically caused by the introduction of skin contaminants at the time of cannulation. Central venous catheters have the highest rate of infection, followed by arteriovenous grafts. Arteriovenous fistulas have the lowest rate of infection. Infections associated with fistulas are rare, since no artificial material is present. There are two methods for cannulation: the placement of needles into a fistula. The preferred method is known as the rope ladder cannulation. It uses sharp dialysis needles with rotation of the cannulation sites from one treatment to the next. The rope ladder technique requires a single antiseptic application to the skin prior to cannulation and is associated with the lowest rate of infection. Buttonhole cannulation is the creation of subcutaneous tracts between the skin and the fistula, similar to tracts created when piercing ears. Cannulation is with blunt needles inserted repeatedly into the fistula through these tracts. The buttonhole technique is associated with reduced formation of pseudoaneurysms. With buttonhole cannulation, a scab forms at the cannulation site. After swabbing the skin with chlorhexidine, the scab is removed, and the skin is swabbed a second time. Failure to remove the scab and re-sterilize the skin prior to cannulation can introduce bacteria from the scab into the bloodstream. Bacteria can also colonize within the subcutaneous tracts if cannulation is performed incorrectly. Due to the increased risk of infections, the buttonhole technique is used less often these days. Graft infections are more common than fistula infections since they contain foreign material. Most will present with fever, erythema, and tenderness over the graft. Sometimes there might be purulent drainage from the graft needle sites. Graft infections are most common within 6 months of creation, but can be observed later. Usually, graft excision is required with systemic antibiotics. Sometimes in minor infections that are localized, you can do a partial excision and placement of a jump graft, which bypasses the problem area. Thigh grafts have a higher risk of infection than upper extremity grafts. Usually, upper extremity graft infections are caused by gram-positive bacteria. Thigh graft infections more often result from gram-negative bacteria, so empiric antibiotic coverage will need to consider this difference.
So I hope you liked this video. Absolutely make sure to check out the course this video was taken from and to register for a free trial account which will give you access to selected chapters of the course. If you want to learn how MedMastery can help you become a great clinician, make sure to watch the About MedMastery video. So thanks for watching, and I hope to see you again soon.